This conference will now be recorded.
Hello, and welcome to this session called Continuous Glucose Monitoring in Pregnancy, Part 2. This is a continuation of Part 1. My name is Diana Isaacs, and I am a clinical pharmacist as well as the co-director of the Endocrine Disorders in Pregnancy and the CGM program coordinator at the Cleveland Clinic. And I am very excited today to be presenting Part 2, which is going to be more of the application about CGM in pregnancy. So these are my disclosures, and this is also the disclaimer about the webinar. And in terms of our learning objectives today, so we are going to review glucose targets in pregnancy, calculate how to customize and review reports, adjust time and range settings, and configure alerts. We are going to be applying what's called the ICC framework, which is identify, configure, and collaborate. And I'm also going to share a way that I interpret CGM data called the data framework. And we're going to apply that to some real world case studies. And then we're going to analyze how to adjust insulin doses in response to trend arrows from CGM devices. So before we dive into all that, I think it's good to review again why we're here and the importance of hyperglycemia in pregnancy. So this was covered in part 1. But just as a refresher, we know that there's a bunch of complications that can happen from hyperglycemia in pregnancy. And so there are complications both to mom and to baby. And specifically to baby, we worry about macrosomia, we worry about potential birth defects or even stillbirth, shoulder dystocia. We've observed a higher incidence of C-sections and neonatal hypoglycemia, which can increase, NICU stays. In terms of mom, we worry about things like retinopathy, preeclampsia, increased risk of diabetic ketoacidosis. And then also, from treatment, which our first line agent is insulin, hypoglycemia if glucose levels are not, staying in target. In terms of our guidelines, we have different guidance from the various organizations about A1C targets and fasting and postprandial glucose targets. And I've listed out here what we see from ACE, the American Association of Clinical Endocrinology, the ADA, the American Diabetes Association, and then the Endocrine Society. And in general, ACOG is pretty in line with ADA. And so, for most women, we're aiming for an A1C of less than 6% is ideal. And then for fasting, definitely under 95. As well as if we're checking 1 hour postprandial, that's generally when we expect that peak to occur, and we're trying to keep that glucose under 140. And then if a woman is checking 2 hours postprandial, we expect it's going to have started to come down a little bit, and the goal in that case would be to be under 120. And by reaching these targets, we hope to avoid any of those potential complications that were seen on the previous slide. The number of organizations have comments about CGM use in pregnancy, and this is really a moving target that continues to be updated. For example, ADA actually updates their guidelines every year, and ACE recently, although they don't necessarily update their guidelines as often, they very recently, June 2021, put out a new diabetes and technology statement. And so just going through, some of the bullets on here, ACE states that use may be recommended when patients are unable to achieve target glucose with self-monitoring of blood glucose alone, and that CGM is associated with improved glycemic control during the 3rd trimester, reduced infant birth weight, and decreased risk of infant macrosomia. And in fact, the newest guideline also really advocates that any woman, either with gestational or pre-gestational diabetes who is taking insulin, should have access to CGM. ADA states that CGM can help to achieve A1C targets in diabetes and pregnancy, and they do say when used in addition to SMBG. And as a reminder, in part 1, we went through the concept trial, really being some of our most robust evidence about the benefits of CGM, and that was used in addition to SMBG. And then also it states when used in addition to SMBG, CGM can reduce macrosomia and neonatal hypoglycemia in pregnancies complicated by type 1 diabetes. And Endocrine Society states using CGM when SMBG levels are not sufficient to assess glycemic control. So with that review, let's go on and talk about the real world complication. So this is actually taken from Adam Brown from a site called Diatribe, and he states that there are actually 42 factors that affect glucose levels. And why is that important to know? Because when we're monitoring and we're making adjustments, we need to keep these 42 factors in mind to try to figure out, well, what could be the possible cause of the elevation or the lowering, and what then would be the solution. And it really is like a puzzle. And you'll note on here that some of the arrows go up and down. So some things can have more than one effect. So I think, most commonly we think about carbohydrates, right? And that's probably one of the easier things to adjust because we know carbohydrates increase glucose levels. But it does become complicated because fat and protein can also impact glucose levels, but depending on how much and, when it's taken, sometimes it can just have like a neutral effect, and other times it can raise glucose. And trying to figure out exactly how that effect occurs is where reviewing data can be very, very helpful. And this is very individualized from person to person. So for example, caffeine is very interesting. For some people, they have no effect. Caffeine is not carbohydrates, and if it's something like black coffee or tea, it may have no effect. But other people notice that even plain coffee or tea will raise their glucose, and they may even have to bolus for it. And then you can see other things on here too. Certainly the timing of insulin is everything. And so that may be an area, if it's insulin's taken too early, that can cause hypoglycemia, but if it's taken too late, that often leads to the hyperglycemia occurring. So continuing on, activity has, profound effects on glucose levels, but it's also different depending on the activity and depending on the person. So usually we expect, exercise, physical activity, light exercise will lower a person. And that's one of the reasons why, many times we'll recommend, going for a walk after eating. That's one of the great ways to lower glucose quickly. But that's not always the whole story. So depending on if someone's really, really fit, they may go for a walk and not have such a profound effect. It might just kind of stay constant. And then high intensity and moderate intensity can really have different effects depending on someone's fitness level and just, other stressors and, time of day and everything. So sometimes that will actually increase glucose instead of decrease it. And so that you can imagine that would be pretty important for a person to know so they don't go taking an extra food when it really is going to raise them. And then biologic. So sleep quality, which often, gets worse later on in the pregnancy, stress, illness, usually we expect those types of things raise it, but sometimes stress is not so apparent. There's emotional stress and, sometimes often when glucose is higher than expected, that's one of the first things I'll ask about is new stressors. Also, in terms of just some other things on here, infusion set issues for insulin pump users, for the way that the insulin is delivered, if it's accidentally given intramuscularly versus, subcutaneously. So there's just so many different things that can impact those levels. And then to add to that, environmental. So, even the temperature outside affects some people, raising them or decreasing them. And as well as, other things that we want to be mindful of, like expired insulin or keeping insulin, especially in the summer when it's in a hot car or outside. And that can unfortunately, not be as effective, or for insulin pump users, if they're not changing out their cartridges usually every 2 to 3 days. If they go longer, that can often lead to compromised insulin. And then there's a whole lot with behavioral and decision making in terms of just the frequency of monitoring, different choices throughout the day, treatment of hypoglycemia, leading to rebound hyperglycemia, just a ton of things that can happen. So with that, hopefully that provides some kind of background about why increased monitoring can be very, very useful to be able to recognize these different type of patterns and come up with solutions for them. So how do we review a person's data? Well, we would use one of the data management systems that go with the respective CGM device. So we talked last time about how each CGM has their own system. So for example, Libre has Libre View, Dexcom has the Dexcom Clarity, Medtronic's Guardian Connect has the CareLink, and then Eversense has the Eversense Data Management System, as well as Gluco and Tidepool can be used for multiple different devices. Within all of these systems, though, we have the option to customize the type of reports and data that we look at. And if you love data, I mean, you could look at 20, 30, 40 pages of data, although most of us, really don't have that kind of time to look through that much data. So the AGP report is a one-page visualization, and often the reality is in busy clinics, that is going to be the most useful. And then if you want to look at additional information, you certainly can. When I am working with pregnant women, I typically will look at the last week because I'm often following them weekly throughout that second and third trimester, just because those insulin requirements change. But this can be adjusted. So certainly if you wanted to look at 2 weeks or you wanted to look at more longer term glycemic control, you could set this for longer than 1 week. One thing that is perhaps super, super important is the target range. So in pregnancy, that international consensus on time and range states that the target for pregnancy is 63 to 140. And so what that means is when you're looking at your reports, you want to set it to this target range, because if you don't, then you're not really going to know what you're looking at, right? So if you keep it at 70 to 180, you don't really know if your patient is meeting their outcomes. And then in terms of a high glucose threshold, even though yes, the desire is to keep a woman under 140 in pregnancy, we also want to be mindful about alarms and alarm fatigue, and just the reality that if we're aiming for 70% in range, that means she's going to be higher than that sometimes. And do we want something alarming at her all the time? So often, setting it for 160, or even a little higher may be more useful, but that'll be individualized depending on the woman. So this is just another example of how we would go ahead and set the time and range. And this is a good example because hopefully you see in here that the target range is 70 to 180, right? So that is not good. It's not good for pregnancy, at least. So for anyone not pregnant, this would be correct. But the problem is I look at this and I don't really know what I'm looking at. 85% in target sounds great, like meeting the targets. But when I look at this, I don't really know what percentage of that time is over 140. So we just really want to be careful when reviewing data and make sure that we change it to that proper target range so that we know what we're looking at, and we can be making the right recommendations for this data. Now, I do want to put kind of a call out about being careful about time in range. So you will notice, we talked about the goals at the beginning from all the respective organizations. And, I didn't include time in range, but, ADA does recommend, the 70% time in range for pre-existing type 1 diabetes. But one of the things we want to be careful about is that time in range does not replace those fasting glucose and those postprandial glucose targets. So those are still things that we want to look at. Even though, yes, we're aiming for the 70%, we still want to look at those other targets. And I would say it's especially important in a woman with pre-existing type 2 diabetes or true gestational diabetes, because remember, we don't even technically have a recommendation for that population other than knowing we want to be at least 70%. But, there's different opinions about maybe that should really be a lot higher, like even 90%. And so it's still very important to make sure your patients are meeting those fasting and those postprandial glucose targets. And to illustrate this, I am sharing an example of one of my formerly pregnant patients. And you will note on here that, she is 64.2% in that target range. I do have that target range set for 60 to 140 instead of 63 to 140, just because this particular data management system, you have to pick 60 or 65. So she's not quite at 70, but she's pretty close to 70. But you'll notice that orange line represents her median. And where is that running? Well, her average is 134. So even though she's meeting that time in range target, she is not meeting those fasting glucose targets. And that means overnight, she is running a lot higher, which can, unfortunately put her baby, at risk of negative outcomes. And so this is, I just think, important to note. If I was looking at a CGM report like this, it's important that we still want to get that fasting glucose down. I also want to share with you something called the ICC framework. So this was published in August 2020, and it is a framework for optimizing technology-enabled diabetes and cardiometabolic care and education. And it's a way of approaching technology for people with diabetes. And it is basically, trying to identify the right technology for the right person at the right time. And so what that means is, looking at the available devices, how they work and the person's preferences and figuring out what is going to be optimal for them, especially when trying to, pick between, for example, an intermittently scanned CGM or a real-time CGM and their preference towards alarms and alerts and perhaps about, calibration or insulin pump integration. So taking all of that information, helping them come up with the right choice, and then helping them to configure it. So configuring is helping them set up the alerts that are going to make sense for them and not drive them crazy or drive their partner crazy. Also, in thinking about data sharing. So all of these devices, or most of the devices, offer the ability to share data with partners, with caregivers, with the clinic. And, a person can choose who they share, or even if they're going to use a device that has that data sharing capability. And then collaborating. So that is the component of reviewing the data together and then coming up with plans, with recommendations, whether those be lifestyle changes or, changes to insulin and medication therapy. So speaking of configuration, this is where we can really, help a person set their alerts. One thing to use caution about when using a smartphone is that, if a person silences everything, that means they may not get their alert. So that would be something to just to check on to make sure it's not fully silenced. And also, another thing to note is many of the systems have a default where it is going to make noise at 55 and you can't turn it off. And that also is something important for people to know so they have the right expectations. And then this is showing one of the mobile app features. And in this particular example, a person can get a 7-day summary of their time in target range. And tools like this can be really reinforcing. So someone can, be tracking their progress, be seeing, oh, okay, my time in range, increased this week compared to last week. Or, wow, I see on Wednesday I was 100% in range, but, compare that to last Thursday, I was only 85%. So, they can reflect on possible, causes for the differences. So next, I want to talk about how to review data. I think this is a question a lot of people ask, like, okay, so these reports, what do we do with them? And then how do we, communicate and talk to patients about it? So this is called data, and it is a tool for reviewing CGM data with patients. And it starts off with obtaining the data, which often is downloading the data or entering into a portal that is shared with the patient where they have their data is available and you can log in and access it. And at this step, you can take note of their ambulatory glucose profile as well as their CGM key metrics. And when I am talking with a patient about it, whether I'm doing an in-person visit or a virtual visit, which is something I commonly do just because weekly follow-up, it's a whole lot easier if that's done virtually. And so I will usually start off with a global overview, especially reviewing the glucose targets, as well as the concept of time and range, since that is often new to people with the CGM. And then the second step is assessing safety. And this is where you're looking for hypoglycemia, so times below 63, and having an interactive discussion about possible causes and solutions to it. And the reason this is really the first step after obtaining the data is because hypoglycemia very often leads to rebound hyperglycemia and increased glucose variability. So many times, if you can reduce the hypoglycemia, you also can just improve, you can end up improving hyperglycemia and variability all in one. Now, the bulk of the conversation should be spent with the T, which is time and range. And this is where you actually focus on the positive about what is working well and basically ways to replicate it. And I think this is important because it's really easy to get nitpicky with data and just want to focus on the times where it's low or the times where it's high and just want to fix it, right? But that you could imagine to the person who's pregnant and who's living with diabetes is not very motivating. It could feel like, oh man, I messed up again. I can't believe, like, I don't know how to manage my diabetes. I just can't get this right. And it can be really demoralizing. So we try to spend most of the time talking about, okay, well, what is working for you? Maybe it was a certain day where they just rocked it and they got that 100 or 80% in range, and talking about what contributed to those successes. Or maybe it's a certain time of day. Maybe breakfast always seems to work really well, having exact carb counts and eating something similar and just really managing that meal very well. And so we talk about that. Now, the next part, there's two final A's in this review, and it's areas to improve. And I feel like in pregnancy, there's often going to be areas to improve because we know the insulin requirements go up. They go up and up and up in the second and third trimester. So I try to, I make sure women know that so they don't feel like they're failing because they need more insulin. Like that is a natural part of the pregnancy. And so, we pay close attention to when it seems like their requirements may be going up, and we try to address that really proactively when we see that their requirements are starting to go up. Or if we just notice certain behaviors, there may be opportunities like going for that walk after dinner and things like that. And then the last A is action plan, where we're developing collaboratively with the person with diabetes. And I try to always stress at each step that this is information. It is not good or bad. Yes, I know a lot rides on this, right? Like we're trying to prevent those negative, potential maternal and fetal outcomes. But at the end of the day, we all have the same goal in mind, right? And so, there's no need to get stressed about it. Just come up with a good action plan and, move forward and try to continue to increase that time in target range. So just some practice pearls that I think are helpful to know is that we should remind patients that, technically these devices are not FDA approved. Yes, we have a number of studies about the accuracy, but we cannot guarantee the accuracy in pregnancy. And one especial caution is about calibration. So many, two of the devices, the Eversense and the Guardian, require calibration, and the Dexcom G6 has optional calibration. And we want to be careful about over or under calibration. If you have a device that needs to be calibrated and you don't calibrate enough, that will lead to, inaccuracy. But also with the Dexcom, you have this option, and if you calibrate at the wrong times, often that will also lead to inaccuracies. So the best times to calibrate are when glucose is steady, when a person has not eaten recently or not given insulin recently. So thinking like fasting, like when waking up, is a great time to calibrate if needed. But what I see happen sometimes is, people treat a low and it's not coming up fast enough, and then they calibrate, and it's like, it ends up sometimes doing more harm than good in those situations. So I usually advise women to check in the morning, and if it's more than 20% off of their finger stick, assuming their finger stick is accurate, then I would want they could consider calibrating in that instance. And then anytime symptoms don't match the sensor glucose, that is a time to do a finger stick. So unfortunately, the technology is not perfect. Sometimes you get a wonky sensor that just seems to be reading funny. So anytime really, if a person feels that they're feeling symptoms of low, but their sensor's not saying it, or vice versa, they should do a finger stick. I always say, like, when in doubt, just do a finger stick. But the technique is very important, because if you have something sticky on the fingers, like there was actually a study that showed like how these healthy volunteers peeled like a grape or an orange, and they checked their glucose without washing their hands, and it was like 1 to 300 points higher than what it actually was. So that's why I always reinforce, like, you got to wash your hands, make sure that technique is good. And then, a reminder about arm wear may be more comfortable during pregnancy, even though, again, that's not the FDA approved site for some of the sensors. We did have that study we talked about last time with the G6 in particular, showing the accuracy was actually better on the arm. And that often is more comfortable than wearing it on the abdomen in pregnancy. So with that, let's go ahead and talk about some case studies in pregnancy. And I want to start off by introducing Sylvia, who is a 31-year-old female with type 1 diabetes, and she is actually wearing an insulin pump. She's wearing the Omnipod. She also wears the G6 CGM, and she's currently 24 weeks pregnant. And this pump does not work directly, meaning it does not communicate, at least at this time, directly with the G6 CGM. But she does have both devices to be able to see her readings and facilitate insulin delivery. And you can see on here the alert setting she has set for her device. So she has her high set for 170. And although she has her low off, she does have her urgent low on, meaning if her glucose is predicted to reach 55 in the next 20 minutes, it will go off. And she also has her urgent low repeat on, meaning if it continues to be low like that, it will repeat the alarm after 30 minutes. So here is her ambulatory glucose profile report. And the way that these reports work is at the top of the report, you have the CGM key metrics. And then the second component of the report is the AGP itself, the ambulatory glucose profile, which that orange line represents the median. The blue shaded area represents where glucose values run the 25th to the 75th percentile. And then the outer in this report goes from the 10th to the 90th. Depending on the type of report, some will go to the 5th to the 95th percent. You will note in this report, you don't see, on the AGP at least, we don't really see hypoglycemia. However, if you look at the key metrics on top, it's saying 2.2% below 60. So that's where the bottom of these AGP reports will typically show the last 7 or 14 days. And that's where you can see the day-by-day breakdown. But just in assessing the metrics at the top, and again, I've set this for 60 to 140 just because this particular report won't let you do the 63. She is well over that 70%, right? And she's also meeting that target for lows as well. She's 2.2. That goal is to be under 4%. And she's meeting the goals for high as well. She is only 20% over 140. Her coefficient of variation is under 36. So that's a goal too. And then she's wearing it most of the time. She's 97% of the time. So this is meeting all of the targets. So yes, we could say, okay, this is done. She's doing great. But there is still opportunity to discuss the data with her and explore perhaps some areas where there still may be opportunity for optimization. And in this particular example, I have not shown you all of her insulin pump data, which is on a different report, but I just wanted you to get the feel for what does it look like when we see those day by days. And the orange on this slide represents times when her glucose goes over 140. And on this particular day, it does not look like it went below 60, we can see there were a number of times when her alarms went off. And I find this to be really useful because if someone's alarm is going off all the time, that means A, they're getting bothered by alarms, but B, she's probably having to do something to address that, right? So even if a person has no lows, you don't know. I mean, they could be popping glucose tablets every half hour, and that's obviously not ideal, especially because we want to be mindful of weight gain too during the pregnancy. So I can see that there were a number of times where she had her urgent low soon, meaning she was predicted to hit 55, and if she did not, interact, she perhaps would have gone low. And we also see that there's certain times that she went high, and so these could be discussions. But one thing I know is that, every time she went high, she got back into range pretty quickly. So it looks like she's being really diligent about addressing it, giving correction doses, really, being able to treat that. Similarly, I can go ahead and I can look at another day and see what's happening. And on this day, again, I see that there are actually 3 urgent low soon alarms, and just, one high alarm that went off as well. And so this would kind of continue the conversation, as well as talking about some of the points, in terms of what was eaten, in terms of food, physical activity level, stress level this day, sleep quality, and certainly the insulin delivered is going to be really important. I wanted to share with you, this is another way to visualize data that some people find helpful, even when compared to an AGP. So the AGP is really not going to show you that outer 5 to 10% of data. But when you look at a spaghetti graph, it's going to take all of those days and put them on top of each other. And so here, it's a little easier to recognize glucose excursions. So, you'll notice on here, we can see there were a couple times where she really did dip much lower. And we can also see some of those points where she did go a little bit higher. And so this would be data we had not previously been able to see. So one of the things, taking a little, break from the specific report, is in the moment when someone is wearing CGM, what they can do by understanding and interpreting the arrows. And so this is showing this, what it means in terms of when arrows are horizontal versus arrows they can be partially up or partially down, or all the way up or all the way down. And this tool can be very helpful when trying to decide what to do about insulin dosing. And so especially for anyone on a connected pen or an insulin pump, where it's going to keep track of active insulin, meaning if she recently gave herself insulin to correct a glucose value, she can feel comfortable to give herself more because it's going to keep track of how much insulin is still working. And so this can be a tool used in addition to that, where she can say, okay, well, yeah, I'm 100 right now, but actually I've got arrows going straight up, meaning, in the next 30 minutes, I might actually be 190 and I'm about to eat right now. So she could dose as if her glucose is 190, get that extra insulin, and then hopefully prevent that postprandial hyperglycemia. So this can be a great tool, especially because we noticed in this case, there are some glucose elevations after the meal. Looking at this day, going back to her individual data, here we can see, first of all, a lot of alarms went off this day, a lot. But you'll notice around 9 p.m., there's these 2 calibrations right there. So this particular device does not require calibration. And when I look at where these are calibrated, it looks to me like maybe she was having a low, and then maybe it wasn't increasing quickly enough. And so she tried to calibrate it, but that's actually not a great time to calibrate because there is a lag time with CGM, especially when glucose goes low and it's coming back up. And so calibrating at that time can actually throw the whole sensor off. And it looks like that might be what happened, because then we see the trend line disappears. So that could have actually made the sensor go bad. So you could have one of 2 things happen. It can become less accurate, or the sensor could just completely stop working. So that's just an important point about the calibration and being careful with that. Going back to that lag time, because I think this is important too, understanding that there is a little bit of a lag time. This is something that has improved with devices where it's, they say, I think the lag time is like less than 5 minutes now, but there still is a lag time. And so when someone is correcting hypoglycemia, it really is best 15 minutes later to do a finger stick, because that CGM may still say she's low, but hopefully it's above 70. And so you just don't want someone to continue treating themselves because the CGM is saying that they're low and they're not actually low. And this is something that just happens, it comes up all the time. And here we can see there's another day with the calibrations, and the calibration that occurred here, it looks like around 2 p.m. Actually, that one looks to be pretty appropriate because we can see that glucose was steady there. But the other one that is less desirable when it is increasing or decreasing. So this is something I try to look at the reports and then talk to women about. So what's the action plan for this patient? So I know you couldn't see her insulin dosing, but some of the things that we talked about were incorporating that 30, 60, 90 rule before meals, and how that can provide a little bit of extra flexibility with insulin dosing to hopefully reduce hypo and hyperglycemia. We talked about calibrating only when glucose is steady. We also talked about the pre-bolus. So especially as pregnancy goes on, the pre-bolusing becomes more and more important. And especially with higher carbohydrate foods at breakfast, we just noticed, 45 minutes in advance, it's like you just really gotta get that bolus in early on. So we talked about that because there were some elevations occurring after breakfast. And then with pumps, we can do things like temporary basals. And we did note that she had some lows, and one of the patterns through discussing with her that we noticed was that it seemed to be times when she was working that she was more predisposed to going low. And so we talked about that temp basal option. And I would encourage you, if you are reviewing someone's insulin pump data, always make sure you do check when they're doing temp basals, because otherwise you might be inclined to say, oh, okay, well, we need to adjust your basals. But you could imagine if someone is always decreasing their basals and then you think they need more and you tell them to increase it, it's not that they really need to be increased, it's that they need to stop doing those temp basals. So that can be another educational point. And then I would follow up in a week. So I want to share another case with you now that's a little bit different. This is Erin. She's a 33-year-old female, and she has gestational diabetes that was diagnosed at week 26 in the pregnancy, and now she is at week 33. She is wearing the Libre, so she's wearing an intermittently scanned CGM, and she has been, confirming a little bit with self-monitoring of blood glucose, but she's basically not willing to do more than once a day. So she does check in the morning, but part of the reason that, like many women or many people, she wanted to use CGM was because she was not a fan of doing all of those finger sticks. Medication-wise, insulin Detamir, she is taking 20 units twice daily for her long-acting insulin, and then she is taking insulin aspart 16 units 3 times a day at breakfast, lunch, and dinner. So here is her AGP report. And one thing I will say about gestational diabetes is that because the bulk of our data, you remember going about the concept trial, is in type 1 diabetes, that sometimes it can be harder to obtain insurance coverage for gestational diabetes. We hope that will change, but currently at this time, it can be a little harder. And so for that reason, very commonly, we see women with gestational diabetes using the intermittently scanned CGM because of the lower cost. Many people, pay for it out of pocket, even if they aren't able to secure insurance coverage. So that I think is just helpful to know, although we, continuously insurance coverage is changing and evolving. Anyway, here is her AGP. And so you'll notice some things on here, 87% active. So we do have over that 70% time. Her glucose management indicator, that's that average of the A1C, is 5.7%. And her variability is only 24%. So that is below that target of under 36%. Unfortunately, this particular report defaults to the 70 to 180 on here. So that's a limitation, because I look at this and I see, she's 95% in target, but that is 70 to 180. So I don't really know what percentage of the time she is between 63 and 140. Although I can see her average glucose is 98 and her GMI is 5.7, which are certainly very encouraging for those metrics. Here is her ambulatory glucose profile. And again, this is, showing the 70 to 180 based on this report. But we can, definitely note some of the trends that her glucose comes down overnight around 6 a.m. And overall, it's pretty flat. That blue line is representing the median. The darker shaded blue is the 25th to the 75th. And then that lighter shaded blue goes out to the 5th to the 95th percentile. So what I like to do is explore the day by day. And one of the things you can do with these reports, I could have had the choice of just looking at the 14 days at the bottom of the AGP, but you also, similar to what we did with the last report, you can blow these up and see them bigger. And the good news with this report, this is the Libre View system. The last report was the Clarity system. But one of the things you can do in the day by day is make it 63 to 140. So that is what I did. And now I am better able to see what is actually happening here. And those little dots represent every time that she scanned it. So we can see she's like really pretty engaged with the device. She's scanning very frequently during the day, trying to keep an eye on it. Of course, we do notice, a couple glucose excursions there, but we can see she's really attentive to her, to checking. And this is just continuing on with the example showing that, she's attentive. I mean, even if you look at Wednesday, May 23rd, yes, it went high, right? And obviously we don't want it to go high, but the silver lining is look how much she was scanning it. She was like on top of it, right? She knew it was high. She was probably trying to take some action, whether that was giving additional insulin or trying to go for a walk, but we can see she was really aggressive about it. And that's one of the things I would try to focus on in motivating is that, wow, she really took action on it versus dwelling on the fact that, oh my gosh, that went so high. All right, so let's apply the data tool to this case. So for starting off, D, we're getting that information expressing it is not good or bad, it is just data. And we've been reviewing the data weekly with Erin. So she is familiar with many of the concepts. So I don't need to necessarily go through in depth what all of them mean, but it is good to remind her that, the target range is 63 to 140. This report defaulted to 70 to 180 and just explain that difference. And then asking her, how have things been going lately with her diabetes management? And she says, good, I scan a lot, which we see she does. And she said she notices exercise really helps her lower her blood sugars. So assessing safety, what do we notice about hypoglycemia? And, we can look here on this day, the red implies that she went below 63. So having some possible overnight hypoglycemia. But in asking her about it, she did not feel it. So she did not even, in fact, note that it was happening at that time. So she did not feel that. So that's, useful information to have. And it did go back up on its own. So it didn't stay low, it went low for a little bit. It did come back up on its own. And another thing I will just caution you about with CGM is sometimes you can get something called a compression low. And that is where, let's say, a woman is wearing it on her arm and she sleeps on that side and just puts a bunch of pressure on it. It may read falsely low. I don't think that's what happened here because usually when you see that happen, it goes all the way low. It goes very low and then it comes up abruptly. So I don't necessarily think that's what's happened here, but that is something you want to acknowledge when you're looking at these reports. Now, there's another tool that we can use with this one that allows us to see all of the low glucose events. And this is called the snapshot of hypoglycemia. And when we look at this, we note that there's 3 low glucose events. Although, I think this report was 14 days. So it's not like, that's not so many. But we would want to just verify, are they really low? Could it be compression lows? And also, if she's not having symptoms and she does get alerted to them, to confirm that it's really low before treating. Now, the lows weren't too much of a concern with her. Let's talk about time in range and focusing on the positive and what is working well. And if I pull out this day in particular, I mean, look at that. She's in range the whole day. And so we can talk about that, what's working well. And she says, at breakfast, she's pre-bolusing, and that seems to be, pretty effective at not causing her to rise. I mean, she wasn't even anywhere close even to that 140. So really staying under those targets pretty well. And also talking a little bit more about, well, what is contributing to your success. And she's been saying she's trying to walk for 15 minutes after meals to prevent her glucose from spiking up too high. And so that's certainly great to see that. And then next, we can go ahead and I like to ask permission to explore areas for improvement. So say, okay, we've looked at all the things that are going well. Would you mind if we just spent a little bit of time talking about some possible areas to opportunities for improvement? So looking at that, we could pick out a couple times or a couple days. In here, I picked these out because we know that there's some elevations after dinner. And so, yes, I pointed this out earlier on the 23rd that she scanned a lot. She got it down quickly. So that was certainly the silver lining of it. But let's still talk about, well, what's the why there? Why is that happening? And she says, sometimes she is, eating popcorn. But she also notices sometimes she feels like it spikes even when she's not eating after dinner. So that may indicate that she needs a little bit more insulin with her dinner, perhaps. So what are we going to go ahead and do? Well, we take that information together and come up with an action plan through shared decision making. And so what we decided to do was to increase her aspart to 18 units at dinner time, reinforce scanning and confirming with, self-monitoring of blood glucose at times where, it may say she's low or high and she's not feeling symptoms. And then just reinforcing all those positive changes that she's been making, like walking after meals, pre-bolusing. I mean, she's really doing a great job with her management right now. And then, I'm a big fan of utilizing the team. So continue to work with dietitian, diabetes care and education specialists, and having weekly review of the glucose levels. And then, one thing that also can be helpful is, using a log or entering in the device when she eats, so we can better see, well, what exactly is 1 hour versus 2 hours after eating. Sometimes that helps with some of the conversation, and that is something that can be done within these devices and the apps, like logging exactly when the meal is taken or when the insulin is taken. So those are some possible opportunities as well. There's even, I'll just add to that too, there's actually a lot of mobile apps out there that you can use that will allow you to do things like take pictures of the food. And for example, there's like SugarMate that pairs up with the G6 and allows a person to take pictures of their food, and then you could look at that report together. And so that's like an easier way for a person to not have to necessarily log their food, but where you can kind of see, okay, are there any opportunities, especially in someone like Erin who is doing more set doses and isn't carbohydrate counting. So with that, I know we've gone through a lot of information in these two parts. Hopefully you've seen that CGM has many benefits, especially when used in addition to SMBG. And while CGM key metrics and time in range are very helpful, they don't necessarily replace our goals of fasting blood glucose and postprandial glucose targets. So we still want to be, encouraging patients to achieve those targets and monitoring those. And then guidelines at this time recommend CGM as an adjunct to SMBG and not to completely replace it. And just due to the different calibration requirements, lag times, sometimes wonky sensors, we definitely don't want anyone throwing away their meter just yet. And then the data is very valuable to view both in the moment as well as retrospectively to make treatment changes. And these here are the different references for the slides, as well as any permissions that were obtained to present this information. And with that, I want to thank you for attending this presentation and wish you all the best.